And yes, TIO 2026 definitely is rocking and rolling with these electrosurgery demonstrations. And before we dive into the next series of demonstrations, let me welcome our new panel, Anita Asgar, who is in Chicago these days, Holger Thiele from Leipzig, and Daniel Blackman from Leeds. So let's now continue with our electrosurgery demonstrations. And again, who else can do this better than Adam Greenbaum? So, Adam, the floor is back to you for demonstrations of Basilica and Lampoon. Let's go.
It's great. Welcome, everybody. Can you guys see my slides okay this time?
Yeah.
Right. Okay. Uh, Nicolas, you asked me to show, I guess, our current thoughts on Basilica and Lampoon. So I have recorded two cases in the last couple of weeks. This case, just let me catch up my memory here because so this case was a degenerated 21 millimeter mitral flow. Obviously, this valve with a 17 millimeter internal diameter, and this valve degenerated by aortic insufficiency. The left and the right leaflets are both flailed. I'm sorry, the left leaflet and the non-leaflets were both flailed. But in review of the CT, the right leaflet was felt to be the one that would potentially cause coronary obstruction. There was some concern about the left, but since that was severely flailed, that is not a great leaflet for leaflet modification. So the decision was to perform basilica of the right and then protect the left just in case. And the planned approach was to do what's called balloon assisted basilica to augment the splay, but still get the benefit of a controlled cut with basilica. I think embolic protection should be up to the operator's discretion. We placed it in this case. You saw the baseline imaging with the severe aortic insufficiency, and you saw the left coronary anatomy. What you can see here is the degenerated mitral flow with, excuse me, the severe insufficiency. It's hard to see in the short axis, but when you go into the stomach, you will see the severe insufficiency. You can see the severe, let me just show you. Here's the severe insufficiency from the stomach, and you will see the baseline hemodynamics here in a second, which are quite impressive. Complete equalization of diastolics and very, very large pulse pressure. Some people say, can you do basilica or leaflet modification when you already have severe AI? And the answer is you can, but I would move things along. And maybe another indication for basilica as opposed to unicorn. One big advance for this technique for us is to use a deflectable sheath, particularly the right. People struggle with the right, which is why I chose to record this one. That is a medium curl agilis. Again, if you are going to do leaflet modification and you are going to use a deflectable sheath, do not put the tabby sheath in because you need all the working length for the agilis. So if you were to sew your Edwards sheath in, and it could be sticking out 7 centimeters. If you use even a dry seal before you want to use an evolute, it's too many centimeters that you're losing. So we will typically just go sheathless with the agilis, and then we will swap out afterwards. The medium curl agilis, let me go back. I'm sorry here. So I think I hit the wrong. And let me get back to where I need to be. Should be playing again. Okay. Medium curl agilis. carefully coming over the arch with embolic protection. The most common guides that we use for a right is a multi-purpose or a JR4. I find the multi-purpose works great for TAV and TAV. They typically start with a JR for surgical valves. You can straighten the tip a little with your hand of the JR4, make it what's called a short tip, JR4. The problem with the right coronary where people struggle is if they don't use the agilis, they are around the greater curve. The JR is pointed tangential. The burn is tangential, and it's hard to snare. What you are going to see with the deflectable sheath is we can flex the deflectable sheath to get over the right coronary sinus and then turn the JR to get it perfectly aligned. The left view is the front view, which is always obtainable for a right coronary. The side view is a compromised view. You can almost never get a side view of the right coronary, but you just need something. I typically am just pure left lateral so that I know I'm pointed toward the leaflet and not toward the sinus. So what you will see here is that we are looking by TEE to see where our guide is. You can see in the cross-section view, your bottom right image, that we are close to the non-commissioner. We are not in the middle of that leaflet. So Vasilis, Dr. Babilaris, is going to flex the agilis and then clock the JR so that in that bottom left picture, we are perfectly perpendicular to the leaflet and in the center. And in the bottom right image, we are pointed toward the leaflet. That can be confirmed by TEE, which we'll take a look at in the center top image to show that we are now more equally between the two posts. So this combination of an agilis and a JR or a multi-purpose works great. You can see now in your bottom right image that our catheter is equally between the two posts. So I find that that's been one big advance to Basilica, particularly for rights. It is also helpful for lefts if your AL is just not big enough. By bending it over to the inner curvature, you will essentially size up your AL. An AL2 becomes an AL3, and AL3 becomes an AL4. Once you're comfortable, the system is the same. This is an 014 quick cross catheter and a 20-gram Astata wire with no tip on it. And again, at 50 watts, energize and push through. We only push through a few millimeters, and then without energy, you can advance it farther down. That's to prevent any injury farther down in the ventricle. You can use your TEE to show that you did traverse at the base, equally in between the posts. And of course, your long axis view can show you that you are in the LVOT and not somewhere where you don't want to be. Now it's time to snare the wire. You can cross it with your other access. This is typically a 6 French JR4 guide, a single loop snare, and then we will snare the wire. Typically, we like to snare up high, right underneath the valve to make sure we don't get around any cords. This patient happens to have a replaced mitral valve also, so we weren't as careful about it, but typically just want to make sure that you're in the middle and you snare in the LVOT. Once we've snared the wire, we will break the wire into the guide and lock it down here. We will not externalize, and that's because we need to go ahead and do our ballooning here and do our flying V and stuff, so that all that gets done before we exteriorize. Why do I like balloon-assisted Basilica? In this case, just to give you a second, my thoughts about that. The advantage of Basilica to us is the controlled location of the cut right in the middle. So we think that maybe the best combination of everything is to aggressively balloon the base so you can get a really wide splay, but finish the cut with Basilica so you know it's right in the middle, as opposed to potentially a cut that you might get all the way up the commissure with Unicorn, for instance. So that was our technique here. This patient's risk was mainly an SDJ issue, meaning the sinus sequestration. So it would also, what you do would depend on ultimate risk. Here you can see that after traversal, there's really no change in the hemodynamics. What we're going to go on here to do for the balloon-assisted basilica is to start with a small coronary balloon. Depending on how tough or calcified the leaflet is, you can go to small. The small is a 1.5. Here maybe a 2 or a 3. I can't remember exactly. Once we make a little bit of room, we then take that off, and then we drive um, a peripheral balloon over. The peripheral balloons that we use for balloon-assisted basilica will be somewhere between 6 and 10 millimeters, depending on what you're trying to accomplish.
les écrans, s'il vous plaît.
In this case, because it was mainly a sinus sequestration issue, we chose to just go to a 6. But if I really want to get the biggest split possible, I'll go as big as 10. I know that a 10 is not going to accidentally tear the leaflet to its free edge. So I think once you get bigger than that, you'd maybe start to get into issues where that might happen, depending on the particular surgical valve. So here you're going to see a 6 millimeter peripheral balloon go up. You can clearly see the waist of that balloon get taken out. And so now we have a nice hole at the base of the leaflet, but we will then go on to create the flying V and finish the laceration with controlled basilica. So we will take that balloon out. We pre-place an 035 torquer on the microcatheter. We advance the microcatheter just till there's a hand width of wire after it. We'll place a TUI on and an 014 torquer on the back ends. That locks the relationship between the microcatheter and the wire. And now we will go ahead and make the flying V right in front of the microcatheter. Interestingly enough, the cheapest, oldest microcatheters are actually the best here. The quick cross, the fine cross. You really don't want any braiding in the catheter. You don't need any of that fine metal that's used to give these catheters the ability to twist, for instance, for CTO work, because actually you really just want plastic. So this is, I can't remember if this is a fine cross or a quick cross. Once this catheter is made, we will, once the flying V is made, we'll do our push-pull. You can add a little extra wire. You can push the JR guide that's in the LV down to make a nice, what we refer to as a nice belly of wire to make the push and pull pretty quick. We went through this technique during the demonstration and during the last case, and eventually deliver your microcatheter through the leaflet. It should go pretty easily if you have balloon assisted it. You can see even with the 6 millimeter hole here, no big difference in hemodynamics. This was well tolerated. We'll cut the bend on the wire. We'll put the torquers, the 014 torquers on the back end. We'll hook up the Bowie, all the things that we went through in the last demonstration, to basically lock the relationship between the wire and the guides. When you do your pull, you don't want the guides to slip on the wire. You need the guides to pull the wire. So all these torquers will lock that relationship. And then you will make sure that you're lined up and you're perpendicular. When you look in this front view, the two catheters should be superimposed. And when you look by TEE, what you can see in that bottom right image is that we are perfectly perpendicular. We're in the middle and we are perpendicular to the leaflet. If your LV catheter gets to a commissure, you may be intentionally cutting at the commissure, leaving a big flap. That's not what we want to do. We want the cut to be in the middle. So in our front view, they're superimposed. In the left view, they're side by side. Now we would increase to 70 watts. We would flush saline or dextrose, and we will pull. If you used an Agilis, you need to back the Agilis up now so that you have enough gap between the two catheters so that you actually can pull the guide back. And the Agilis will tend to want to drive down. It will want to advance forward. So someone will just need to hold some negative tension on the Agilis as the second person pulls the two guiding catheters. The third person will flush. And then someone else, a fourth person, sometimes will hit the Bowie. So what you can see here is a pull. Someone is holding the Agilis started to dive down. It was pulled back. And now the laceration has been created. Pretty soft pull. If you get the energy correct, it should be pretty easy. You'll see more aortic insufficiency. Again, in the upper right, you can still see pretty well tolerated. There's a flailed left leaflet, a flailed non-leaflet, and now we've created a laceration in the right leaflet, still well tolerated. Maybe another advantage over unicorn in these cases, particularly if you planned on doing, you know, taking a 14 millimeter balloon and making the full say the full destruction of the leaflet before implanting an evolute, for instance. Here we are going on to place our coronary guide, in this case, a balloon to protect the left, and we'll go on to perform a valve-in-valve TAVI. Here we will fracture this mitral flow pre. So here is a true balloon going into 14 atmospheres to fracture before we put the valve in. This patient will go on to get a 20 millimeter S3 inside their mitral flow, and then we will make our final assessment. So while I let this run, we certainly can talk about anything you want to discuss on the balloon-assisted basilica part of it, and be happy to answer any questions.
Yeah, this is this is very impressive again to witness and to see. But Anita, maybe the first question for you. Obviously, a mitral flow is an externally mounted, are externally mounted leaflets. Does that make a difference if you have traditional or conventional internally mounted leaflets versus externally mounted leaflets, or is the technique and the indication similar?
I mean, I think the risk of coronary obstruction obviously is higher with the externally mounted. I think Adam shows you, it makes us look really easy in how you do this. One of the questions I would have had for Adam is, for those of us who don't do as much basilica as you do, can you talk to us a little bit about these specific devices like shortcut, and when you would choose basilica versus shortcut? How do you make that choice?
So I think an electrical cut is safer. These leaflets, in this case, this was again flailed leaf. The right coronary leaflet was not very calcified. This valve had degenerated by by aortic insufficiency, and I think your mechanical cut may have been okay here. But in general, when these valves degenerate by stenosis with recurrent calcification, I find that an electrical cut with vaporization of tissue, I think, is safer. I think it's more controlled. I think you're less likely to avulse the leaflet off the commissure. And again, you want the cut here to be in the middle of the leaflet. So in our feelings, our concept on this is that we would always prefer electricity over a mechanical cut. There will be people who will disagree with me, but I think that's safer for the patient. I think you could use the balloon augmentation of basically widening out the base to augment your splay, and you can be aggressive. In this case, a 6 millimeter balloon, we've gone up to 10. But then get your final cut nice and straight and right in the middle so that it splays the way that you want it. So this is our preferred and current strategy, independent of internal versus external mounted leaflets.
So Adam, but just for the audience, it's also important to realize that you're not deploying the valve in the leaflet, right? So you're making a laceration, a tear of the leaflet. So this is different from unicorn. It's important to realize that, right? So with a unicorn, the valve is being deployed within the leaflet. Here, you make a cut in the leaflet, but you will deploy the valve in the central lumen.
That's correct. All we did here, this was a basilica. The only difference was that let me see if I can get to it again. The only difference here was to augment the basilica, we ballooned the base. So here's the ballooning here to a 6 millimeter balloon right here. Okay, that will widen the base. We have not broken this leaflet to any free end. We've just made a bigger hole in the bottom of the leaflet, and then we will go on to do basilica. So this is what we refer to as balloon-assisted basilica. The goal here is not to deploy the valve in the leaflet. The valve is still being deployed in the center. Okay.
Adam, it's Dan Blackman here in Leeds.
Uh,
I've got a couple of questions. Sorry, Nicolas.
Go ahead.
So, I mean, the bench models were not clear as to whether you get a better display with balloon assisted. What evidence do we have that it's more effective? I mean, it's intuitively one would think it, especially with if you go up to 6 or even 8 or 10 millimeter balloons, it should be. But have we got any clinical evidence to suggest it's more effective, or we've got more bench models or to suggest this is a better way to go? And when are you using balloon assisted kind of routinely now to optimize display, or in select cases?
Right. So we did have some initial bench testing that suggested a little bit of benefit with coronary balloons up to about 4.5. We have recently redone it with larger balloons, and that paper, bench testing, that paper will come out soon, hopefully May or June, to show that it definitely increases display to significantly, maybe 30% actually. To me, I still prefer the controlled midline cut that you get with Basilica. So the only thing we're doing by adding the balloon is increasing the efficacy, but maintaining that control. When you do intraleaflet deployment, right, the goal here would be to deploy the valve and translocate the leaflet to the opposite side. If you take a 12 or 14 millimeter balloon and you accidentally create the tear to the free edge, there's been no control of where that tear is located. It could be all the way in the corner. The wire now centralizes. The big flap of tissue comes back in front. You deploy your valve in the center now, and you have now coronary obstruction because the entire leaflet is where it was originally. So the fact that you know that you make the cut here in the middle is what we're still trying to preserve. We're just trying to increase the efficacy with display. So hopefully you'll see the data soon that a bigger balloon helps. Now,
so would you advocate routine balloon assist?
Pretty much, yes. Yeah, so we have gone to it pretty routinely. I will say that completely no risk of the balloon assisting from a tab and tab situation because you have a cage that will hold the leaflet. We haven't seen many complications from balloon assisted on internally mounted surgical valves. There have been a few cases of externally mounted leaflet valves where now the leaflet was really floppy. The leaflet flopped into the left main, and we still needed to stent afterwards to place a stent to secure that. So I would say that it is important to check your final images at the end after you've done it, just to make sure. So I think going and doing a dedicated right coronary picture, such as this one, through the cage of the tabby valve tells you indeed made a successful cut, and it would also double check that there is no leaflet material in front of the coronary.
Okay. Holger, any comments from you before we go to the next case?
Yeah, so we have seen Mohammed also in the previous session, who is doing all the Basilica procedures at our institution at the Heart Center Leipzig. So far, I can remember when I've done them together with him, we haven't used balloon-assisted Basilica in many cases. So that's how do you make, so far I've understood you do it routinely nowadays, mainly based on models and on hemodynamic assumptions. So are there any convincing data, although I know there are only limited data on this, that this is really the better approach than in comparison to a normal Basilica?
No, we obviously don't have definitive data on that. And I don't do it every case. I think it would depend on what the risk of obstruction is and what you are trying to accomplish. For instance, if it is just an STJ problem, the coronary is up high, you know that if you just get any split like this, you're going to get flown to the sinus, you're going to be fine. Maybe straight up Basilica is okay in those situations. But what if there's an STJ problem, but the coronary is also very low? Well, now when you do your Basilica, the coronary is sitting way down here where this splay is not necessarily as much in a standard V that you would make. So in that case, maybe we would widen out the base with balloon-assisted basilica. So that combination may lead me to do it. If I have a VTC problem, but the VTC is 4 or 3.8, maybe I just do basilica. If I have a VTC problem, but the VTC is 0, well, then maybe I need more. I want to make sure that my V is widened. So I think it's about the specific anatomy. I don't think you need to do balloon-assisted basilica in every case, but we thought we would show it so that people can understand the technique should they want to do it.
Yeah. All right. I think in the interest of time, we may need to move on because also the cat lab is waiting for us. Adam, do you have one more recorded case to show us?
I do. I have a case of balloon-assisted lampoon, which I will tee up for you here. Okay, so
yeah, let's try to do this within 10 minutes.
Yep.
Yeah, perfect.
We're going to move quicker. This is a 31mm surgical ATS ring with now recurrent severe mitral regurgitation. That, of course, was bought by Medtronic, called a Simulus. It is a flexible ring. It's a 31, so it's large, and it is leaking. The plan for this case was balloon-assisted lampoon, followed by valve in ring TMVI. The access is really simple. This is a 26 dry seal in the right femoral vein. You can use a 24 technically, but for antegrade lampoon, you need 2 deflectable sheaths. They're kind of 12 French outer diameter, so there's a little bit more room in a 26. Plus, you can free mount your 29 of Sapien directly on the balloon. So this is single axis 26 French dry seal for the case, and we have a 9 French sheath in the other leg in the artery for a balloon pump. That is it. We do not pace. So this is basically 1 artery for the balloon pump after a lampoon and 1 to deliver. This is transeptal. The transeptal is done at about 3.5 high and posterior, whatever you would think would be best for the ultimate valve delivery. Your front and side views are determined by CT. And I will show you now 2 deflectable sheaths have been advanced through the same septostomy. You can see the view waves here, no gradient. So through 1 Agilis sheath, you will bend and float through the center. Through the second Agilis, there is a 6 French JR4 guide. And that combination will be used to get at the base of A2 just inside the leaflet. And again, there's a Dostato 20-gram tip wire and a fine cross microcatheter. You will use the combination of MPR and fluoroscopy if you have a visible ring to show you where you are. You can see the upper left picture. We're a little lateral. We're pointed a little lateral. But in the upper right picture, we have a nice trajectory perpendicular to the leaflet just inside the ring. So with the combination of the Agilis, pushing the Agilis brings you lateral, pulling the Agilis brings you medial, flexing it will change your trajectory more medial, unflexing it will change it more lateral. So with that combination, you can see that I'm going to flex the Agilis and we will get that catheter more lined up at A2. If you counter your Agilis, you'll be more base. And if you counterclock your Agilis, you'll be more towards the tip of the leaflet. So you'll see us taking time here. If you look at the bottom right image, you can see that our catheter is quite just inside the ring. If the other catheter is bothering your imaging, you could just pull it medial for now. It doesn't really matter. Again, traversal is the same as it is with all these other techniques. 50 watts, push it 2 millimeters ahead, and then push it the rest of the way without energy. If you notice, there is no veno-arterial rail here. Again, single access for this procedure. No other venous access, no other arterial access other than for the balloon pump. You can see that by TEE, we are clearly through the leaflet at the base and in the middle. And now we'll just swap out and snare this wire in the left ventricle to simplify the procedure. If you are going to snare in the left ventricle, it's nice to expand the snare just underneath the valve, push it down, make sure you stay in the center, you don't get wrapped around any papillary muscles or cords, and then confirm that once you've snared it. So by TEE, we will look to make sure that we haven't wrapped anything. Once that's done, you can add a little wire, you can create a little belly in the left ventricle, and we will go on to do the same balloon assisting that we did in the last case. This is a 3 millimeter coronary balloon. Again, the leaflet is going to be slightly ventricular to this ring. You'll see a little bit more hole in the leaflet, not the central regurgitation, but that you've created a hole now in the anterior leaflet itself. We will go on in this case to take a 10 millimeter balloon. To create an even bigger hole to help splay this leaflet. You can see the waste being taken out. Again, the goal here is not intraleaflet deployment. The goal is not to use the balloon to tear to the free edge. It's just to widen the base, to widen the ultimate splay. You will see more flow through the hole in the leaflet now. We'll go on to create the flying V. We will advance it just like we did last time. We will line up our catheters. We'll make sure that the flying V is just outside the two guides. We will lock all the catheters like we talked about in the last session. And now we will line up these catheters. We will take the time to set up the two Agilis catheters so that they are perpendicular to the leaflet, so that they are bent appropriately, so that our fulcrum is high. So that the fulcrum is high up, so that when we pull the guides are pulling straight. And we will use TEE to make sure before we do this pull that we are where we want to be. So look in the right image here. We are directly perpendicular to the leaflet at A2 at the base and in the middle. Once we've confirmed, we're going to energize at 70 watts. We're going to flush and we're going to pull. And what I want to show you here in this picture, I intentionally left it in, but when we go to make this pull, you'll see that we start to drift medial. So I stop. And what I do is I advance both Agilis catheters. I flex them more. I counter them so that they're on the anterior leaflet. I reposition them so that I know when I make the pull the second time, I can get the fulcrum up higher and more vertical so that when we pull this time, we pull straighter. Because what we don't want is a tangential slice from lateral to medial. We'll often start, if you look in the bottom right image, we'll often start a little bit lateral to account for a slight medial pull, but here you'll see the second attempt, and now we come much straighter and we've pulled through. Once you see by TEE that you've created a nice laceration, you can go on to perform your TMVI. So you'll see much more mitral regurgitation. The balloon pump helps. We've never really had much hemodynamic compromise, but the balloon pump seems to just help enough that you can now take your time for the rest of the procedure. You disassemble your system, you perform your septostomy, and now you go ahead and deploy your mitral valve. Again, while we let the rest of this play so you can see the deployment, I'm happy to answer any questions about balloon-assisted LAMPOON. We do not base during our mitral interventions. I find that if you allow the ventricle to stay in diastole, there's more room for the balloon and you can get a more stable deployment. Once the balloon is inflated enough, all the inflow has been stopped, so there isn't much movement anyway. You can take your time, you can go nice and slow, and you can make sure you're happy before you finish the rest of the balloon dilatation.
Adam, one thing I was
Or if
interested
the
in both
balloon-
these cases. One thing I was interested in both these cases is that you snared after crossing rather than crossing through the snare. Do you think there's an advantage to that? I mean, I think less experienced operators might be concerned that would give you a little bit less confidence that you've truly snared through the leaflet and you haven't gone outside the anatomy and the LVOT.
Sometimes the guide and the snare in the LVOT can make it harder for the imager to help you with alignment. So sometimes we pull it back. In the Basilica case, he couldn't quite see, so we pulled it out. And in this case, yes, we just left the pigtail for clarity for the imaging, and then we went ahead and snared it. I do believe that if you only burn 2-3 millimeters and then push the rest of the way, again, you're still putting the LV you're still putting the snare in the LV. So you are still snaring the LV. You just now have to back up the wire and push it through the snare once it's open. What you can do is you can twizzle the microcatheter through the leaflet. You can then take out the wire and put a bend on the wire. So now you can more easily advance into the snare. So sometimes that's a nice technique because sometimes people struggle with getting the straight wire into the snare. So I think it's dealer's choice on that, whatever you feel most comfortable with.
Adam, is the composition of the mitral leaflets, is it different from the aortic leaflets when you're doing these procedures? Do you sense that the mitral leaflets or the aortic leaflets are more vulnerable for a complete tear, or is there no difference?
Well, the anterior mitral leaflet is longer than most of these aortic leaflets, so I think you're unlikely to get a full tear unless you go to a really big balloon. So I think that's one difference between them. I think that in general, if you are doing Lampoon or leaflet modification for long leaflet, and particularly for valve and ring, the anterior leaflet seems to be usually pretty pristine. There's not a ton of calcium on it. Valve and MAC, a completely different situation. But for valve and ring, it's usually a long anterior leaflet. It's usually pretty good. So I think it handles these balloons and a Basilica pretty well.
All right. Thank you very much, Adam. So in the interest of time, we have the cath lab in Bordeaux waiting for us. I would like to thank you and all the panelists. I think it's fair to say that these techniques represent the very best of innovation driven by clinical necessity, and today's demonstrations have given us all a great deal to reflect on. So for the panel, the entire panel, and Adam, please stay around for the live case that is about to begin. So let's transition to the live case session.